Hi, everyone. Good afternoon. My name is Carolina Cardona, and I'm an assistant scientist in the Department of Population, Family, and Reproductive Health. And today I'm very excited to be leading the webinar to listen to the presentations of our master's students. It is a great pleasure to listen to the presentations of the students today, and it is a culmination of a month of hard work, and I'm very excited to see all the work that they put together. During this presentation, we're going to listen to a 10-minute presentation from each of the students, and then we will have a 5-minute follow-up discussions for Q&A. We might be able to extend a little to give more time for the Q&A portion of the webinar because we have only 3 presentations today. If you have any questions, you can also please put them in the chat, but you can also keep them and just ask them after the presentation. We will give priority to the questions posted by students, and then we will open the mic for others to join. Today, our first presenter is Shae Nicolaisen. She has a Bachelor of Science in Biology from Duke University, and her area of interest is child and adolescent health. Shae is going to be presenting her project that looked at advancing food security, social protection, and economic opportunity among young adults in Brazil. Shae, the mic is yours.
Good afternoon, everyone. My name is Shae Nicolaisen, and I'm here to present a policy analysis focused on Brazil's food security and youth-oriented policies. This analysis aims to inform and advance policy recommendations that strengthen economic opportunities and expand social protection for young adults in Brazil, with the goal of reducing food insecurity in this population. I want to thank my reader, Dr. Kristen Mari, for all of her help and guidance in this process. So, looking at the background and context, so looking at the issue, food insecurity is defined as when people lack regular access to enough safe and nutritious food for normal growth and development and an active and healthy life. Hunger is a more acute phase of food insecurity that is defined in some policy documents. And specifically within Brazil, youth are defined as those aged 15 to 29, with young adulthood being 18 to 29. And looking at data, the Brazilian Institute of Geography and Statistics does collect food insecurity data at the household level, but there is no available disaggregated data for youth or young adult age groups. Still, this age group is important to focus on as young adulthood is a time of increased economic and social vulnerability, with young people who experience food insecurity at having greater or poor nutritional, mental health, behavioral, and relationship outcomes as compared to their peers who are food secure. And specifically within Brazil, it is an exemplary nation for its success in combating hunger and extreme poverty, achieved largely through the government's Fome Zero or Zero Hunger policies. These policies were first implemented by President Lula in 2003 and address both the structural drivers of food insecurity as well as provide emergency food relief to those in need. And so looking at the principal policies under Fome Zero, Bolsa Familia is a conditional cash transfer program that provides monthly cash transfers to low-income families, and families must meet specific conditions, including school attendance for children, as well as regular health checkups and vaccinations. The program is targeted using a national registry system to identify and reach Brazil's most vulnerable populations. There is also the National Program of School Food, which provides free nutritious meals to students in public schools across Brazil from pre-K through high school, with menus designed to meet age-specific nutritional needs. As well as 30% of the food must be purchased from local family farms, promoting both food security in children and stimulating local agricultural economies. And then thirdly, there is the Family Farming Food Acquisition Program, which supports small farmers by purchasing their products at fair prices and distributing the food to public institutions and food insecure populations, which encourages sustainable local food systems. And so following the implementation of the Fome Zero policies beginning in 2003, Brazil saw dramatic improvements in economic and social outcomes. And so Brazil was able to achieve the Millennium Development Goal of reducing extreme poverty by half in 2007, as well as saw a 54% decrease in severe food insecurity between 2004 and 2013. This led Brazil to be removed from the UN hunger map for the first time in 2014. However, following 2014, food insecurity began to rise once again with an economic recession, a change in political administrations that emphasized economic austerity over spending on social protection programs, as well as the COVID-19 pandemic. However, Lula was reelected in 2022 and has refocused policies combating hunger and poverty. And since then, there has been an 85% reduction in severe food insecurity in 2023. And so FOMI Zero social policies recognize the need for job and income generation to address hunger and food insecurity, but current programs fail to adequately support young working age Brazilians. With high youth unemployment levels at 20% and informal employment levels at 42%, young adults face significant socioeconomic vulnerability, leading to higher rates of food insecurity. Furthermore, major national social protection programs like Bolsa Familia and the National School Food Program target mainly families and young children, leaving young adults without sufficient coverage. And then while Bolsa Familia has been generally shown to have positive outcomes on employment, its income cap for eligibility has been shown to inadvertently discourage young beneficiaries from pursuing formal work, especially among disadvantaged youth. And so the subsequent analysis focuses on youth policies designed to strengthen employment opportunities and expand social protection for young adults, given the strong link between economic vulnerability and food insecurity. So looking at education, Pro Jovem Integrado is a program that targets youth who did not complete elementary school, offering basic education and vocational training in classrooms, but lacks an on-the-job training component. Looking at apprenticeships, Jovem Aprendiz is a national program for youth combining theoretical training with work experience. There is a national law that mandates all medium to large companies allocate 5 to 15% of their positions to apprentices, but there's only about 25% compliance with this law. And then considering employment services, these services are historically underutilized by youth, and they focus on job matching and training for those eligible for unemployment insurance, which is limited to workers who were dismissed from their positions without just cause, therefore excluding youth who are first-time job seekers. And then Brazil is also in the process of implementing a program called Estação Juventude, and these centers will act as hubs for coordinations of services for health, social assistance, and employment, and these are implemented at the state and municipal levels. And so to strengthen youth employment outcomes, Brazil can look to successful international examples. So in Colombia, Jóvenes en Acción is a program that provides a mix of classroom instruction and on-the-job training to unemployed youth. And the program has significantly improved employment outcomes through its on-the-job training component. Looking at Australia, its Youth Allowance program offers financial assistance to young people who are studying and training or seeking employment. And the program has been effective at promoting continued education and improving long-term employment prospects for youth. And then finally, in Finland, Ojamo centers serve as one-stop shops for youth who are under 30, serving as points of integration for employment, education, health, and social services. And early results show positive outcomes in job placement, training, enrollment, and housing support for young people who participate. And so drawing on these gaps and successful international models, Brazil has several policy opportunities to improve economic and employment outcomes for its young adult populations. So integrating on-the-job training into programs like Pro Jovem Integrado will better equip youth with the skills that they need in the evolving job market. And policy recommendations can also include a stricter enforcement of apprenticeship laws with fines for noncompliance, as well as offering financial incentives such as a subsidized or sub-minimum wage for employers in order to encourage the hiring of apprentices. A key recommendation is also to integrate and co-locate youth services, addressing low awareness of services as a barrier to participation. So expanding services in centers such as Estação Juventude and other municipal centers is recommended in more states and municipalities nationwide. And then looking at Brazil's unemployment insurance scheme, it currently requires unjust dismissal for eligibility, therefore excluding first-time job seekers and those who are informally employed. And this highlights the need for a national financial support program like Australia's Youth Allowance to help youth pursue education and employment opportunities. Looking at Bolsa Familia, expanding the eligibility criteria by raising the income eligibility cutoff to ensure a living wage for single-person households can provide greater economic support for young adults, as well as adding a conditionality that rewards high school completion in order to improve youth preparedness for the formal job market. And then lastly, states and municipalities should explore utilizing existing youth centers as well as creating new ones like those under Estação Juventude to provide free or subsidized meals to young adults and out-of-school youth, offering both nourishment and a space for skill building and community engagement. So the combination of these policies would strengthen employment readiness and opportunities for youth, provide social protection through new and expanded allowance and cash transfer schemes, and provide direct food provision in order to improve employment, poverty, and food insecurity outcomes in this young adult age group. And so to conclude, addressing food insecurity requires both structural policies to increase income and employment, as well as provide direct food access for those in need. Young adults have often been overlooked in the development and implementation of Fome Zero policies, but with the Lula administration refocused on reducing hunger and poverty, now is the time for action to improve the outcomes for this population. And so by collaborating with international partners, as well as civil society and private sector stakeholders, Brazil can create policies that ensure immediate food access for young adults while laying the groundwork for long-term economic security. That is all. Thank you.
Okay, great presentation. I enjoyed a lot looking at all the data that you showed us from Brazil. I used to live in Brazil 5 years ago, I think, and I think it's a fantastic and fabulous country. I'm going to open the floor for some Q&A questions. So if anyone has a question, please either raise your hand or feel free to unmute your mic. Nicole, I see your hand up. Please go ahead.
Hi, Shae. Great presentation. So I don't know if you are aware, but recently there was a farm to school program that was passed in Maryland. And I was wondering if you looked into any other programs that were similar to the one that you talked about in Brazil, either in the United States or in other countries in the world.
Yeah, Brazil is pretty unique in its national policies that require farm to table food systems for school and other public institutions. And a food systems planning course I took here at Hopkins, I know there's a lot of local movements like here in Maryland and kind of more at the state or regional level that are looking to implement in the US. And Brazil has really been a successful example of this internationally that I think we could learn from here in the US and other countries as well.
Cool, thank you, Shae.
Yeah.
Anyone else has a question? And we prioritize questions from the students, and then we will open the floor for others to ask. And let me check the chat to see if there are any questions. Christy Mary says, great job, Shae.
Thank you.
I don't see anything on the chat. Okay, I have a general question, Shae, given that is because of, oh, wait, David Page has a question. He says, great presentation. The next for food is metabolically at its maximum during the teen and young adult period. My question is more general. If you wanted to share some of your, from the policy review that you've stated, you've seen something related to more of Bolsa Familia's effect, and if you want to comment on any specifics of that.
Yeah, there have been, I read a systematic review that looked at the effects of Bolsa Familia. It's, I think, definitely one of the largest conditional cash transfer programs that's implemented at the national level in the world, and it has overwhelmingly positive impacts on education. It's really shown improvements with a conditionality for school attendance and improving children's attendance at schools. It also has a conditionality for vaccination, which has improved childhood vaccination rates, as well as improving economic stability, food security in families. So the overall outcomes on both employment, education, and health have been positive across the life course.
I see your hand up, and this is the last question that we're going to take, because then we have to go into the next presenter.
Yeah, I was just wondering if you would be able to talk about how your field placement informed kind of the formation of your master's essay question, if it did at all.
Yeah, so I did my field placement in Fortaleza in Brazil. And so my work there was with youth centers looking at nutrition in adolescents who attended the city's youth centers, which offered the sort of education and training and sports services that I was recommending. So I think there are a lot of examples also at the municipal level within Brazil that can serve as an example of something that can be scaled up at the national level to improve employment readiness. And these centers also did not yet serve food, but that was a policy recommendation that we discussed in my time there. So I think that's another opportunity.
Thank you, Shae, for that great presentation. I'm gonna just
Thank
clap
you.
the camera. Now we're gonna pass on to Caitlin. Caitlin Rempson has a Bachelor of Science in Public Health from the University of Miami. Her area of interest is child and adolescent health. And today she's going to be talking about, I think this is related to her field placement in Zambia. And she's gonna present us about the application of a human-centered design to develop an intervention that addresses mental health and internalized stigma among adolescents and young adults in Ndola, Zambia. Caitlin, the mic is yours.
Thank you so much, Carolina. Let me share my screen. And great job, Shae. That was such a good presentation. Yeah. Great. Are you able to see my screen okay? Okay, well, thank you so much for being here. And as Carolina introduced, my name's Caitlin, and today I'll be presenting on work I did in my field placement in Zambia, titled Applying Human-Centered Design to Develop a Mental Health and Internalized Stigma Intervention Among Adolescents and Young Adults Living with HIV in Ndola, Zambia. So first, a little bit of background about HIV among adolescents and young adults in general. They'll be called AYA throughout this presentation. So about 2 in 7 new HIV infections are from within the adolescent and young adult population. And of those AYA population living with HIV, over 1/3 are not receiving any ART treatment. So this means that targeting the AYA population is a key way to decrease new infections of HIV. And one way in which this can be done is addressing a very adaptable, modifiable variable, stigma, because stigma often prevents AYA from attending HIV clinics and receiving any necessary treatment that they need in general, but also specifically in Zambia. So to address that need, a program called Project Yes was created, Youth Engaging for Success. This included peer-to-peer mentoring programs, one-on-one and also in a group setting, with the peer mentor being someone who has been living with HIV and also a young person as well. So they have that shared connection. And the intervention was successful in reducing internalized stigma, increasing ART adherence, and increasing viral suppression. Now, although Project Yes overall was very successful, there was still a large gap of 45% of the AYA were referred to a healthcare provider throughout the intervention, and the main reasons for this were experiences of violence and suicidal ideation. And for the purposes of this project, we'll focus on 30% of the population who was referred to an HCP were struggling with suicidal ideation. And this is significant because depression and suicidal ideation are associated with lower ART adherence, and that amount of 30% aligns with the common literature that about 1/4 of adolescents and young adults living with HIV are experiencing symptoms of depression and suicidal ideation. So an area necessary to target. So to address this, the project decided to add a mental health component called Self-Help Plus to Project Yes, to add that dimension to address the need within the population. So Self-Help Plus has been proven to reduce mental health disorders and psychological distress. It's a stress coping mechanism, so it's more providing tools for prevention of severe mental health disorders rather than being used as a tool to treat those disorders. So when we take Self-Help Plus, add it with Project Yes, we get Project Yes Plus, which is the intervention that we were working on creating with the overall goal to decrease internalized stigma, improve mental well-being, and increase ART adherence among adolescents and young adults living with HIV. So to do this and create Project Yes, we used a human-centered design approach, which is a very iterative, cyclical approach where we really went in with empathy and trying to understand the population, as well as an optimism that we can solve all of the problems as if we have limited resources, which we know isn't the case, but it was the best way to go about listening to everyone's ideas. So we used the double diamond approach for human-centered design and went through these phases of discover, define, develop, and deliver. And throughout these processes, we had 3 separate workshops. 2 of the workshops were within the discover and define phase, and they were with former Project Yes mentors and participants. And we just got their initial thoughts and ideas, and they helped with translation. And also within the discover phase, we had our own team of experts who had implemented Project Yes originally, as well as meeting with experts who have implemented Self-Help Plus. So just getting different ideas and developing more and more questions. Then we also had a prototyping workshop in the develop phase with adolescents and young adults living with HIV in Zambia for a total of 3 days and caregivers of those adolescents for 1 day. So this is an example of some of the information we gained from working with the youth peer mentors and understanding concerns they had, such as the importance of creating a safe space, which we then developed into questions that we could act on, such as how can a safe space be created for the youth? And if you go 3 rows down, you can see that we spoke with a professional in Brazil who was implementing Self-Help Plus in schools. And we asked, one of their key concerns was about the translation from English to Portuguese. So we knew this was an area that we also needed to really focus on. Yes, so from those questions, we then grouped them together into themes and we came up with 6 main how might we questions, which you can read through. They're very big general questions to try and fit all of those different questions we came from the YPM, our own team, and experts we spoke with as well. So one of the questions was, how might we structure and schedule the intervention to best encourage full participation? And then from those questions, we created activities or matched activities such as a month in your life that could be used to answer these questions in the prototyping workshop. So these are the activities we then use with the adolescents and young adults within Zambia. So from that prototyping workshop, it was very successful and there was so much enthusiasm for the intervention, and it helped very promising that in general, the integration of mental health into AYA HIV care was really our AYA were super excited about it, and so were the caregivers. So we know that it's something that is very interested and accepted in the population. We also found that caregiver involvement is really critical. Caregivers were really excited about being in a space where they were with other caregivers sharing a similar experience of having a young person living with HIV, as well as learning different ways to help treat or not treat, to help care for their adolescent and young adult living with HIV. Now, the opposite side of that is that many of the young people were really excited for their caregiver to be involved, as it allowed for an opportunity for tension to be solved between the pairs. But they thought only those under 18 years old should be required to have a caregiver, and those older it should be more optional, as some of them are married and have children already. And then kind of talked about with the caregivers, the importance of shared experience was really highlighted, which is a key part of Project Yes already, but just the youth being able to be in a space where they have this lived shared experience was really important. So some adaptations we made, some logistical adaptations include group size. A more medium-sized group was favorable to a larger or smaller group. The materials, we weren't sure if they should be just in Bemba or English in Bemba, but both materials, both languages are necessary. And then we also added a joint session for AYA and caregivers, knowing that caregiver involvement is critical. Then for language and cultural translation, this is personally one of my favorite findings. The translations was very difficult from English to Bemba because mental health terms tend to be so abstract, at least in Self-Help Plus. So a term like grounding doesn't really mean anything in English unless you get the Self-Help Plus training and you learn about it. So it was difficult coming up with those specific translations. So really having a collaborative approach and working with the adolescents and young adults who live there to make that adaptation was really necessary. And then finally, implementation learnings. A safe space was really defined as being about the people and not the place, which really emphasized the importance of giving trainings to make sure the youth peer mentors know how to create that safe space feeling. And unsurprisingly, confidentiality is crucial within the HIV care setting. So some limitations we had was that we didn't have any father or grandparent caregivers participating. We more so had young women, like aunts and mothers. And then all of the participants were recruited from one single urban HIV clinic in Zambia. So we were really lacking that rural perspective. And there was limited input from those younger adolescents living with HIV. I think it was just a large environment, and the older kids were more comfortable to speak than the younger ones. So overall, Project Yes really addresses a critical need for care of mental health among adolescents and young adults living with HIV. Using a human-centered design really made it culturally relevant, and using a randomized control trial will be our next step in making sure Project Yes Plus is effective. So thank you so much. These are a list of so many people I'm grateful for. My PI, Julie Dennison, reader, Krista Mari, my family and friends who are here, thank you so much. And then to all the youth peer mentors and everyone along the way. So thank you.
Caitlin, that was a great presentation. And
Thank
it
you.
really shows like you had a wonderful field placement experience. Great job.
Thank you.
I'm gonna open the floor to questions, and we prioritize questions from the students. So if you have any question, please raise your hand, or you can just feel free to unmute yourself or post it in the chat and I can read it for you. We don't see any hands up or anything in the chat. Any questions from the faculty and other members? I do see in the chat that Kristen Mary says fabulous, Caitlin.
Thank you.
Yeah, I don't see any questions in the chat or any hands up. I do have a question. I was very interested if you will be involved in the next steps of this intervention in the RCT, and if you can tell us, and if so, if you can share any of the details about it.
Yeah, so I hope to be. I definitely will be from the US side, but unfortunately, I don't think I'll get to go back to Zambia. But the next step is we just finished the actual human-centered design process. It's quite lengthy, like going through the insight table and really figuring out what is truly feasible in a real-life setting for what the adolescent and young adults suggested. So what can actually be done versus what they want. So we're finishing making those adaptations and determining the sample size. But something that's I think is very interesting is from all this, we actually decided to change the age range from to focus on 15 to 18 because the caregiver involvement was so highlighted and they felt the older kids, the caregiver involvement should be more optional. So we kind of decided to cut down that age range. Also, for research reasons, you have to get parent consent for under 18. So that's one huge change that's been made, is that we'll just be looking at that age range of 15 to 18 now.
Sounds like a very exciting project that you will be following on.
Yeah.
Congratulations on this work, and look forward to reading more of your work and see where you go after this program.
Thank you.
I don't see any questions. I don't see any hands up, so I think we're good to go with our next presenter. Thank you. Hailey, if you wanna start sharing your screen. Our third presenter is Hailey Spaeth. She has a Bachelor of Arts in Economics and Anthropology and Global Health Environment from the Washington University in St. Louis. Hailey's area of interest was women's sexual and reproductive health, and today she's going to be presenting some of her work that she's been doing on reproductive empowerment and the achievement of contraceptive preferences among Ugandan women. Hailey, the mic is yours, and we can see your slides. Looks good.
Great. Thank you, Carolina. And great job to Shae and Caitlin. That was very interesting. Yeah, so as Carolina said, the title of my essay is Reproductive Empowerment and the Achievement of Contraceptive Preferences Among Ugandan Women, applying the WGE-SRH framework. And a big thank you to my reader, Linnea, for all of your feedback and thoughts throughout this process. There we go. Yeah, so my essay was in the form of a research report. So I'll start with the background of my analysis, then move to objectives, methods, results, and conclude with some key takeaways. Starting with the background, there are over 12.7 million women of reproductive age in Uganda, and the Ugandan government has committed to advancing empowerment and gender equality as part of their sustainable development goals, including ensuring universal access to sexual and reproductive health and increasing reproductive rights. But the specific linkages between empowerment and reproductive health outcomes need to be further understood in the literature. Empowerment has been defined and measured in many different domains. So for example, empowerment in the family structure is distinct from empowerment in the economic sphere, and both of these would have different implications on health outcomes, but empowerment is often reflected in the data as one aggregate indicator. And in studies focused on contraceptive use, higher levels of empowerment and agency have been linked to improved contraceptive uptake, but there isn't a ton of information about the underlying mechanism and key motivating factors. And little research has focused on the relationships between empowerment and intention to use a contraceptive method. So the domain of reproductive empowerment was developed to focus specifically on areas of empowerment that are most critical to reproductive health. So my analysis applies one reproductive empowerment framework, which is called the Women and Girls Empowerment in Sexual and Reproductive Health, in order to better understand linkages between empowerment and the achievement of contraceptive intentions. So the empowerment measures for my analysis come from the WGE-SRH framework, which is shown here. And it was developed from discussions with women and men across 4 sites in Ethiopia, Uganda, and Nigeria. And the framework encompasses sexual behavior, contraceptive use, and pregnancy, but I'll be discussing in the context of contraceptive use. But the framework understands empowerment as a pathway and highlights important factors that shape and determine people's ability to achieve their reproductive health goals. So the existence of choice and the exercise of choice are both measures of contraceptive empowerment that exist along this pathway. It starts off with the existence of choice, which is shaped by one's goals and motivations related to contraceptive use and tries to capture one's perceived ability to make contraceptive decisions. And then the existence of choice informs the exercise of choice, which is the second measure of contraceptive empowerment that I use. And this reflects levels of agency and a person's ability to act on and negotiate contraceptive decisions. And the idea is that both of these empowerment measures greatly influence the eventual achievement of reproductive health goals. So this analysis applies this framework to panel data to examine the relationships between empowerment, contraceptive intentions, and the achievement of those intentions among reproductive aged women in Uganda. So for my first objective, I use cross-sectional data to assess whether the existence of contraceptive choice is associated with one's intention to use a contraceptive method. And then for the second objective, I used panel data to examine whether the exercise of choice scale moderated the relationship between intention to use or not use a contraceptive method and the achievement of that use or non-use at follow-up. I analyzed 2 phases of data from the PMA survey in Uganda, and the phase 2 surveys were collected between September and November of 2021, and then phase 3 was collected about a year later, in September and October of 2022. And the study population was a nationally representative sample of 1,720 Ugandan women of reproductive age who were not using a contraceptive method at baseline. Intention to use contraception was the outcome for my first objective. And for the second objective, I used 2 models to separately assess achievement of outcomes. So the first one included 661 women who intended to use contraception, and their outcome was contraceptive use at follow-up, whether they achieved that intention. And then the second included about 1,000 women who didn't intend to use contraception and assess their achievement of that at follow-up. I used unadjusted and adjusted multivariable logistic regression models for both of the objectives, and separately from the main results, I conducted some sensitivity analyses to verify the validity of my results because of ambiguity in survey responses for both contraceptive intentions and pregnancy status. And then all of the multivariable analyses included covariates related to contraceptive use, and those were taken from the phase 2 baseline survey. So final models included pregnancy status, fertility intentions, and among some other key sociodemographic factors. And all of the analyses were conducted in Stata. So moving on to results, this table shows the survey items representing the contraceptive empowerment scores for the analysis. So each of these rows represents one survey question from PMA, and each of them received responses on a 5-point scale, which ranged from strongly disagree to strongly agree. And then each score was summed and averaged to calculate mean values for the final existence and exercise of choice measures that I applied to the model. I reverse coded the scores for the existence of choice to ensure consistency across all of the empowerment measures, so that 1 represented low levels of empowerment and 5 represented higher levels of empowerment. And then the mean empowerment scores were analyzed categorically as quintiles. So as you can see, there are 5 items that comprise the existence of choice measures, and these focused on perceived implications of using family planning, from side effects to fertility complications to relationship conflicts. And on the 5-point subscale, the mean score was 3.22 out of 5. And then exercise of choice had 3 individual survey items, which focused on negotiating family planning use with their provider or partner. And the mean scores were slightly higher for exercise of contraceptive choice at 3.96. So for objective 1, which looked at the relationships between existence of contraceptive choice measures and contraceptive intentions, we found that women with the highest scores for the existence of contraceptive choice subscale had twice the odds of intending to use contraception compared to women with lower scores, and women who intended to have children within the next 2 years had 44% lower odds of intending to use a contraceptive method. So fertility intentions also significantly influenced intention to use a method. And then for the second objective, this was applying the panel data to look at the relationship between the exercise of contraceptive choice and the eventual achievement of contraceptive intentions. The results were more inconclusive for this objective. The achievement of contraceptive non-use was associated with the exercise of contraceptive choice, but these results did not remain significant after sensitivity analyses. And I didn't find any significant association between exercise of choice scores and the achievement of contraceptive use among the women who intended to use. However, compared to married women, women who had never been married had almost 3 times the odds of achieving their intention to not use contraception. Yeah, so moving on to limitations. The PMA survey assessed contraceptive intentions only among women not currently using contraception, which may have introduced some selection bias and prevented me from examining intentions among people who were currently using. Also, the contraceptive intentions were self-reported in the survey, so they are potentially subject to recall bias, social desirability bias, or misreporting. And measurement of contraceptive intentions could have been strengthened by asking about intensity of intention, so how strongly people wanted to use or not use a method. And then finally, some of the indices within the empowerment measure may hold greater relevance for certain groups of women in the sample than for others. So for example, not all women in the sample currently had a partner or husband, which made questions about discussing family planning with a partner potentially less applicable for them. So for key takeaways, the study added to the limited literature which examines contraceptive empowerment and contributed some new evidence from a culturally grounded empowerment framework that was developed in Uganda. And the results from Objective 1 emphasize the important role of reproductive empowerment in shaping contraceptive intentions. Although the longitudinal findings were inconclusive, this does align with other longitudinal research from Uganda showing a big discrepancy between Ugandan women's intent to use and the subsequent achievement of use or initiation of use. And so more research is needed in this area to identify the various factors that influence this pathway between formation and achievement of intentions. Thank you. I think we can move into questions now.
Hailey, that was a great presentation and great job. I also want to say that I had the pleasure of being Hailey's advisor, and it has been a pleasure to see how she's evolved throughout the program, especially her data skills. I was amazed by how she was able to learn them very quickly, and she's now a very agile data analyst researcher, especially with longitudinal data.
Thank you.
I'll open the floor now to questions from students first. And if you have any question, please raise your hand. Or you can also type them in the chat. I do see in the chat that there are congratulations from Linnea and from Julia. And Linnea says, totally agree with Carolina, a joy to advise. I don't see any questions from students or any hands ups. Any of the faculty or other members that have any questions that you want to ask Hailey?
Hi, Carolina. This is Celia. Can I ask a quick question?
Yes, thank you, Celia.
Thanks. Hi, Hailey. This was a really great presentation, and really appreciated your explanation of everything. I had a quick question related to the second aim, the longitudinal analysis. And apologies if I might have, oh, sorry, I thought my video was on. Apologies if I missed this when you were explaining the models. In your second set of models, did you adjust for people's existence of choice, or were you just looking at that relationship between exercise of choice and the achievement of intentions?
Yeah, so the primary independent variable was the exercise of choice, and then the outcome was achievement. And then I kind of separated it out into people who had an intention to use or not use. And then, so yeah, that was the primary independent variable for the second objective.
Okay, but well, and I can follow up separately. I was just kind of curious because in the work, developing that framework, the exercise and existence of choice pieces like fit together for that process.
Mm-hmm.
So I'm just kind of curious if maybe you would see a relationship if that was adjusted for in the model, or maybe you tried that and you didn't see one. So I was just kind of curious about your results, but I'll follow up separately. Thanks so much.
Yeah, no, that's really helpful. For this round, I kind of separated them out into the first objective and the second objective, but that would definitely be something interesting to explore in future work.
Yeah, great work. Really great work.
Thank you.
Cecilia. Thank you, Hailey. Any other questions? I don't see any hands up or questions in the chat, but I do have a question, and this is just curiosity as well, similar to Celia. In the scale that you showed that there were like individual items, and I know that your argument here is to see if the scale has an association with later behavior, but I was just wondering out of curiosity, especially because your results were inconclusive in your second aim, if you tested the individual items in the scale as having some association in the later behavior and whether you found something there.
Yeah, I did actually. For the second objective and the exercise of choice, none of the individual items were statistically significant either, but for the association with intentions in like the cross-sectional analyses, there were really strong associations between like the beliefs about side effects and intention to use. And so I found that really interesting, just like how those beliefs really strongly inform people's decision making at that stage.
That's very interesting. Thank you for sharing, Hailey. So Hailey is our last presenter, and this session is slightly shorter because we have only 3 presenters instead of 4. So if there are no other questions, I think we can close this presentation. And if anyone has questions, just please unmute yourself. Or if anyone wants to say something, you can also unmute yourself. Yeah, I don't see anything. It was a pleasure to listen to you all 3 present the work of your master's essay. All of the 3 presentations were fantastic. You did a fantastic job, and it was very interesting and enlightening to see all of your findings. I hope that you all the best for your next steps, and congratulations.